started with our first presenter, who is Dr. Sarah Woolsey with HealthInsight Utah. Dr. Woolsey is a board-certified physician in family medicine, as well as the Utah Medical Director with HealthInsight. She's worked in quality improvement in outpatient settings for over 10 years with primary care and has 13 years of experience with underserved populations in Salt Lake City. She maintains an active in- and outpatient practice with the Community Health Centers of Salt Lake City. Dr. Woolsey was selected to enter the first class of the Innovation Advisor Program by the Centers for Medicare and Medicaid Innovation in 2012. She's a graduate of the University of Illinois Chicago School of Medicine and completed her residency with the University of Utah. So, Dr. Woolsey, thank you so much for joining us, and I'll turn it over to you.
All right, thank you so much, and I hope everybody is well out there with the various weather conditions across the country. As she introduced, I'm both a quality improvement medical director and also a clinician in a federally qualified health center. So I'll talk today lessons we learned in the Beacon project, which gave us access to lots of different care settings, and then also speak from my experience as a provider in a federally qualified health center, low resource setting, some of the things that we have seen work in hypertension control. So just a brief overview of the Beacon community for those who are not aware. In 2010, the Office of the National Coordinator of Federal Grantee awarded 17 communities a Beacon grant, and the idea that we would use Health IT to improve care for patients. And what we found is that Health IT is a part, but that patient engagement, provider workflow, and learning how to use those tools correctly is actually going to be the key to moving the ball forward. We worked on that project through September 2013, and we were a convener for multiple organizations in our community, and eternally thankful for all of them for their sharing and all that we learned together. Our aims in our Beacon were related to diabetes type 2 in adults, and I'll just point your attention to the 10% improvement in patient control and blood pressure. And we were using the NQF number 140/90 for the patients in our entire community catchment area. We had a lot of range, so you'll see here clinics clustered around the Wasatch Front, Salt Lake area, and then we had rural providers in Tooele County and Summit County. We were lucky enough to work with 53 clinics in the 3 counties, 330 care providers, 24,000 patients, and a variety of experimental settings, large employed physicians, independent physicians, like my practice, a federally qualified health center, including a homeless health center, and nonprofit office practices. We had a primary care focus in our project. I'll just show a couple slides of our overall improvement. You'll see that we didn't hit our 10% control improvement. We hit about 6%, 6.5%. But we really moved the ball for hundreds of patients and maintained a lot of others in control. This is a graphic we used for our team throughout our project, and I'll just have you note the yellow line is the same graph as you saw before, showing our overall community metrics, but the robust clinics, they were lower resource settings that lack technical assistance, lack some of the infrastructure that our Beacon program was able to provide them. And you can see that they started lower, but they finished higher. And I just want to speak to any of the ASTHO teams that feel like they're starting behind the 8 ball. You have a huge opportunity to improve and can do so quickly. Our success themes, I'll just go over, in general, were actionable data, education, and obviously developing processes that remove barriers. For the purpose of the time on our call, I'm going to talk about the actionable data part. And there's 2 things that I think are important. Number 1, oh, that didn't work, is patient point of care data. So what happens right there at the moment of taking care of a patient, and then obviously quality data. So quality data. All of you have joined the ASTHO project probably because you're interested in being part of something bigger. You know that tracking data and having a collaborative model makes a huge difference. So that's not any information to you. What's going to help in your individual projects? First, we found that IDing all your patients is critical. And the first step in our project was like, wait, who's the baseline population? We used claims data in some settings, pharmacy reports, lab data, payer reports, old registries that clinic had used. We found that the problem lists were not necessarily up to date in electronic health records, for example, so we had to go back and look for all those patients. There may be someone who'd been seen very regularly for diabetes, who had a diagnosis of hypertension, but it just never got on the problem list. If you're doing a hypertension project, you might not catch that patient who would benefit from your improvement. So look for different sources as you're getting your baseline population settled and getting it into your electronic record. That will hold significant gains in the future. I say make a list and check it twice. Engage your providers. Get those lists to providers. See who they know is missing. See who they can say, oh wait, that patient has now moved on to a different practice, or they're deceased, or they're in a nursing home, or under the care of a different provider. So you can engage your providers and begin to get that baseline data to have some credibility with them. A second thing that's key is electronic medical record documentation. It seems simple, but it's not. Ensure accurate documentation in your particular record. Retrain everybody on the right place to put it and the right way to check it. In our system, we found that if you put a left or right arm designation next to the number, that our electronic health record wouldn't track the number at all, and it would appear as if the patient didn't even have a blood pressure. So little things can really mess up your ability to pull your reports. If you retrain everybody, if everybody's documenting the right way, suddenly your hypertension registry report becomes trustworthy, and providers begin to look at it in a new way and say, hey, that's actually a good number, and I'm going to listen to it as they ask me to make some changes in how I practice. Use meaningfully. Most providers are under the meaningful use process to attest. They need to demonstrate that they're using their electronic health record to improve outcomes. They need to learn how to do that. Engage the people that are being paid to help you, your vendors, your regional extension center in your state. In the Beacon project, we found peers to be very useful. Someone using the same electronic health record as you might have tips and tricks about how to do these reports better, how to make sure this documentation goes better. So peer-to-peer teaching ended up being important for us. I'm going to stress run charts. In the Beacon project, one of the things that our team developed for our practices, and especially those smaller, robust practices, was the ability to see their data in a motivating way. This is an example of a team. They could log on and look at this information pulled directly from their electronic health record. It was a run chart, provided monthly updates as to their number of patients in control. It showed them their target goal that they needed to get to. It showed them the community average of their peers so they could see how they were doing amongst the Beacon practices. And it gave them a sense of where they were at. At the bottom, you'll see that it had also patients to goal. We gave them information saying, hey, how many patients will it take for you to hit your goal to get back under control? So they know how high the target is and how many improvement cycles it's going to take. So even if you just have meaningful use reports, which are often by provider level, consider an Excel spreadsheet or a module maybe ASTHO is providing to you to track data in a way that gives run chart and goals. We think it really helps motivate the process. Okay, now data, patient point of care. This is one of my super duper pet peeves that can make a huge difference in how we do blood pressure care. So training on blood pressure measurement. I was fortunate to be converted by Dr. Barry Stoltz, a hypertension expert at the University of Utah, who really, really focuses on an excellent diagnosis of blood pressure using good technique. If you have a good blood pressure, if you have a culture that excellent blood pressure is taken and recorded in your system, your providers are going to be more likely to act, and you're going to hit that therapeutic inertia problem. Number two, you're going to avoid overdiagnosing patients and over-treating people. You hate to have people have a side effect of a hypertension medication because you're over-treating a number that you had in your office. If your numbers are good and you can trust them, those interactions are all going to go more smoothly. Dr. Stoltz always says, it seems like this is easy, but it's not, okay? And the quote from the JAMA article that it's really difficult. I watch videos sometimes of providers delivering care, and blood pressure taking is one of the worst things you'll see. Patients standing up, doctors holding their arms. Very, very interesting thing that we have in our provider delivery. A correct cuff size. You don't want your staff running around to find the right cuff size. You want them to know when they need it and have it available. This all requires reminders and regular retraining. It's not something you can do once and then forget. And these are just some examples of a poorly taken blood pressure can influence your results significantly. How important is this for our Hypertension Collaborative? And this is a graphic from Welch Allen that I've just always liked because it shows pictures of the right way to do things and can be a prompt for both patients and providers of care. Purchasing automatic and blood pressure cuffs, just something to think about, not always affordable for everyone. We chose to do that in my FQHC center. We bought 3 for the 16 rooms that we have. We use a centralized machine on a roller. Our staff love them. We calibrate them regularly. We use them for most, not all patients. And it takes the attention off that the fleeting cord cough, and it now has you pay attention to how your patient is seated, if they're talking, at what point in the visit are you taking that blood pressure. So I want folks to think about that as an option to improve your information you get at the point of care. Okay, data at the patient level. So how many of us would send a patient out in the world on insulin without a glucometer, without any way to know the effects of the medication they're using to control their chronic disease? How many of us send patients out into the world without an option to know their blood pressure and the impacts of when and how they take their medications? So patients can be a really big part of having good data for blood pressure. So a self-management program, we suggest an FDA-approved home monitor. Here's some links to places to look for those. Standardizing an order in your electronic health record for the machine you guys want to use. We've gotten familiar with a particular cuff in our setting, so it's automatically in our EHR. Our staff knows how to use it. Our providers know how to use it. If a patient calls, most likely they'll have that monitor so we can troubleshoot with them on the monitor. You also want to get the large cuff in the order set and the guidance for a large cuff so you don't forget to order it for patients. And then we like the patients to come back for in-clinic training on how to use it. Again, I know the information's good when I know the patients had a training on how to use their cuff properly. Then when I get those reports from home, I think, hey, we can act on this information. We trust it over time. Develop a blood pressure and monitoring training checklist for your educators. In my system, we have a health educator only once a week, and she's an expert in this training. But I also have clinical staff that on a walk-in basis can help a patient learn to use their monitor properly because they've been trained to do blood pressures properly and they've been trained on the standard model of machine that we're using. Patient education tools, put those in your EHR, put them at people's fingertips. Blood pressure monitoring logs don't have to be fancy. Some of the machines track numbers, some of them don't. I'll show you an example of something we've used that makes a difference, but things are getting more sophisticated, and ideally we'll be using things like portals and apps in the future. In addition, I just want to plug no-charge walk-ins for patients without home monitors. One option for self-monitoring is having them come in and get pressures throughout the week, having your staff do those at no charge. It gives you extra information. 10 blood pressures over 2 weeks for a patient who has time to come in can really give you a window into what's happening day to day and give you an opportunity to change your therapies or check adherence if those numbers are not at the goals that you and the patient have set together. That was also shown to be an effective intervention in the large North Kaiser study in California. So I just want to have people look at that as an option for self-monitoring that's not really a cuff at home. And this is just an example of a Spanish translated grid. This will give the provider information in a graphic model. I have a patient who's very low literacy. Every time he came into the office, his blood pressure was just wacky. Couldn't understand it based on his reports of medication adherence and taking the blood pressure. We began to have him monitor at home, and within 6 weeks, we actually had his blood pressure at goal. And what we learned was his smoking affected his blood pressure, his anxiety affected his blood pressure, the timing of his medication affected his blood pressure, and this was all stuff he learned after beginning to take his blood pressure twice a day and recording it and us talking about it. So I just want to really give you that ability for a bird's eye view in a simple way. This is just a handout in partnership with our Department of Health that's been handed out for patients to understand what affects blood pressure. I just want to, okay, last thing, actionable data, regular reporting. So in the data cycle, what's important is to get your metronome going, to get that regular cycle of showing data, and improving it and refining it as you do your project. Registry review and recall, the RRR. It's a key to population management, especially for hypertension. You want to provide patient lists with control rates to your providers. Ideally, you benchmark them against national data, local data, peers in their practice. Individualized reports really hit home. Use lists to choose self-management patients, so find those patients not at goal and find out what's going on. You could do that in an offline process, not use your precious provider time, but get those folks in for extra off-visit care. You could consider 2-week titration protocols using RNs, pharmacists for the right patients. You can also use staff to check adherence for patients. And then again, plugging the portal. That may be a new window into communicating with patients that avoids phone calls or walking in with paper. I know I'm just getting to where some of my patients have the ability to give me information in a portal email model. So finally, just use your data powers for good. Make them superheroes. Data can motivate. It's the only way to know if you really improved. Point-of-care blood pressure measurement is critical, so the data your provider has at their fingertips is good data and they can act on it appropriately. Patients are your partner for data. Have them get on the team. Develop your metronome for improvement, and then use your data to celebrate success. Nobody can argue when those lines go up that something good is happening. And I'm leaving my information. I'll be jumping off the call about noon, but I'm happy to take questions at my email or phone call. And there's just additional resources at the end for you. These are things we've used to develop our process. Thank you.
Great. Thank you so much, Dr. Woolsey. And we'll have, let's see, I guess if you have to hop off the call in just a few minutes, maybe we can take a couple minutes to see if there are any questions.
Okay.
So any questions for Dr. Woolsey?
This is Lloyd Mitchell. I got one, actually a comment, which is wow. And the question actually, which is probably for the group, is will the slide, can we get the copies of the slides? I'd love to share these around. That was beautifully done.
Thank you.
And yes, Dr. Woolsey, if it's all right, we'll be sharing the slides along with the recording for this webinar. So yes, Lloyd, we can get those to you.
Please do.
This is Melanie in Alabama. I have a question about when you mentioned that you're having people come back to become trained in their blood pressure monitoring items. Anyway, are you able to bill for that part of it at all?
We do not. We do not bill at this time for that. I believe in certain models where we're looking at outcomes for patients. You might find a way to be paid for that, or if you had a skilled RN doing some element of care and adjusting medications, you might be able to bill. But I'm talking about really a pure access issue where the information is more important to me than the bill. And so having that MA available is critical. And I don't have the link in my deck, but I'm sure someone at ASTHO has that recent Kaiser study where they had really good success rates in control of a large population, and this was one of the keys, was walk-in MA blood pressure checks, and they didn't charge patients. That's
great. And just as a preview, we will be hearing from a Kaiser clinician during the February 6th virtual meeting, so hopefully there will be an opportunity to learn more about that study as well. So thank you for mentioning that.
Very good.
Thank you.
Any other questions for Dr. Woolsey before she has to hop off the call? I actually had one for you. I was curious when you're talking about sharing or reporting data beyond kind of internally as a clinic, are you sharing data with any other partners either in the community or at a kind of hospital healthcare systems wide level?
So during the Beacon project, we had our Beacon community, so we had a number of partners that were all participating. And our anticipation is that our Health Information Exchange will provide that ability at some point. So I'm working with our Million Hearts team in Utah to really look at how can we get that information at the point of care EHR information to larger systems, and we're hoping that would happen through a Health Information Exchange. But at this time, we don't have easy ways to do that. In our collaborative, we had lots of partners at the table looking at what we could all do, but now that project's ended, that data sharing at this point isn't occurring, but we're hoping to move that into our HIE. So that's a wish at this point.
Great. Okay, thank you.
And if there's a moment for one other question, I guess I do have one. This is Lloyd Michener again. Given that this was a Beacon project, there was quite extensive. To what extent did you link up with other community agencies, health department, media, so you had a parallel intervention underway? Because you got a pretty big cohort there. And I mean, this was fantastic and well described. I'm just wondering to what other extent you leveraged other tools or mechanisms to further amplify the message.
Yeah, so the Million Hearts project was happening at the middle to late part, and so we had worked extensively with we have a Wise Woman program that works in our Salt Lake County Health Department area. We had the Department of Health Stroke and Prevention group that was active. We also do QIO work, so our Quality Improvement Organization was leveraging. Our partners as individuals had various, so like our large health systems, Intermountain and University of Utah, had initiatives underneath the Beacon project. Media-wise, for hypertension, I don't think we had a specific media campaign around hypertension specifically, more diabetes related. Does that answer that question?
Actually quite well, and I think it's a point for all of us that these programs sit within other wider connected interventions, and part of the work is connecting the pieces, just as you so nicely do within the practices and across the practices. It's connecting to the wider other agendas and activities that are going on, as you just described.
Yeah, and I'll just mention, for health systems that have already done a lot within their system, that benchmarking against the community data becomes really interesting because you may be thinking you're doing well in your system, but how does it appear in the larger community? So if anybody has those opportunities to show providers how they fit into a bigger spectrum of their literal peers in their state or their county, it really can spark interest and look for hotspots and deficits in care. So if you guys have that opportunity through HIEs or other partnering projects, look for it. We found it to be a huge leveraging for getting people interested and aligned around chronic disease.
Great. Well, thank you, Dr. Woolsey. We really appreciate you taking the time to speak with us.
Thank you. You guys made this really easy. And I'll look forward to hearing more about how this happens over time.
That sounds great. Thank you so much.
Bye-bye.
So our next presenter is Dr. Carrie Lejewski, and I'm sorry if I pronounced that incorrectly, but Dr. Lejewski is a family practice physician in Ellsworth, Wisconsin, with the Ellsworth Medical Clinic. She's a graduate of the Marshall University School of Medicine in Huntington, West Virginia, and completed residency training at the University of Minnesota North Memorial Program in 2003. In addition to full-time practice, she serves as the medical director for 3 clinics in River Falls, Ellsworth, and Spring Valley, Wisconsin. And just another side note, the Ellsworth Medical Clinic was recognized as a Million Hearts Blood Pressure Control Champion in 2012. So they've been doing some really outstanding work that has been nationally recognized. So Dr. Lejewski, I'll turn it over to you.
Thank you so much. I appreciate the opportunity to be here and fill you guys in a little bit on what we've been doing here. So we've had a pretty robust focus on quality. We're an independent group of mostly primary care physicians in western Wisconsin, just across the border from the Twin Cities. And Minnesota has been a champion of these types of initiatives, and we've been an active participant with a group called IC3 out of Minnesota, and they had encouraged a lot of these. So back in the early to mid 2000s, we were doing a lot of auditing and putting our data out there and sharing information with all the physicians about quality data, as a lot of the similar things that Dr. Woolsey was talking about. And the Ellsworth Clinic is one of 3 clinics that's part of this group of the River Falls Medical Clinic. And we're a small clinic. There's 2 physicians, myself and one other family practice doctor, and then a physician assistant. And despite the fact that all 3 of us sat on our quality group that all of us were very involved with this, what we were finding is that we had hit a plateau and we really couldn't move the needle any further. And so it was in 2007 that we started talking about, well, how can we make a dent in these hypertension numbers? We were falling usually in the mid-70% in terms of how well we were controlling blood pressure for those patients. And so what we decided to do, because we spent a lot of time kind of beating ourselves up and saying, we the physicians, we the healthcare providers aren't doing enough. And we realized that the part that was missing is that we needed to make it more of a team approach. And so we really did change our thinking at that time to say, okay, how can we use all of the members of our staff to try and maximize outcome? And so we really had to step back and give up ownership. Up until that time, we had a lot of focus on, my patient, this idea of always being in control of your own patients. And so if someone else was seeing my patient with a high blood pressure, they'd get referred back to me for another visit to deal with the blood pressure. We didn't do a lot of care in between visits, so if you were in and your blood pressure was high, it would be a matter of, again, referring them back in to come and see me. And so we started at that time to train our staff and to get them involved to help them see where the barriers were. And we really involved our entire staff, which is about 12 people, so it wasn't too hard to get everybody involved, and asked them to give us some feedback and help us figure out what type of mechanisms we could use to improve blood pressure control. So one of the big things that we talked about at that time was that every visit needs to be a hypertension visit. If you're here and you're being seen, we need to assess whether your blood pressure is controlled, and if it's not controlled, we need to come up with a plan for it. And we really changed our focus from this idea of patients being the patient of a specific provider to saying, you know what, you're a patient of our clinic, and therefore we're going to take care of all of your needs, chronic disease needs and acute care needs at every visit when you come in. So at the time in 2007, we were still living in paper chart world, and our audits were based on pulling charts off of computer lists, and then at that time we would go through and see how we were doing. So we didn't have any computer resources to help us at that time. And so we came up with some kind of low-tech ways to improve. One of the big ones that has worked remarkably well and that we've continued long after we've started our EMR is that we made these little homemade bright red blood pressure recheck magnets. They sit on the inside of the door, but anytime a staff member has checked a patient's blood pressure and it's too high, they put that magnet out on the front. It's a visual cue to the physician that we need to check it and evaluate it and follow up with the patient. And then if I happen to miss it on my way in, on the way out it's sitting right there. And so typically we'd send the staff back in and make sure that it gets rechecked. I also really agree with Dr. Woolsey's information about making sure that staff are properly trained regarding blood pressure checks. It's very important that it's done consistently every time the same way. And patients do start to understand the importance of that as well, which is very helpful. In addition, we came up with some blood pressure protocols. So if a patient was in and having lab work done or some other follow-up with staff, and we also subscribe to the notion that patients should be able to stop by and have their blood pressure checked free of charge. And so whenever they'd stop by, we have protocols in place that let staff know, is this a patient who can be sent on their way? Is it someone who needs to wait and see one of us, or is it someone who maybe needs a follow-up visit again, depending on where their blood pressure is on that given day. And so at the end of 2007, when we did our audits, I was very pleased to see, so you'll see in September of 2006, my control rate, and this was based again on audits of charts, 60 a quarter. And so in September of 2006, over that quarter, I was at around 60% of my patients controlled, and at the end of 2007, I was over 90% of my patients with hypertension who had been in. Their blood pressure had come up or had gotten down to a goal for more than 90% of those patients. So once we went live with our electronic medical record, one of the things that was frustrating to us is that we were not able to that there was no registry system that was built into our EMR. And so we, starting in 2010, asked our computer specialist, our IT department, to figure out ways that they could use the reports we could get off of our EMR system and put them into a way that we could access them like a registry. And so what they came up with is an Excel spreadsheet that dumps into an Access database. At this point, it is used by our care coordinators, and it's updated every couple of weeks, so it isn't live, but it does give us a way to go through and look. And so this is an example of if you run the list for patients with high blood pressure, you can look through and see when was the last time it was checked, what was their last blood pressure, and it is sortable so that you can pull forward patients who are not at goal. Our goal with these lists is to have our care coordinators looking at all of them for all of our patients at least once a month for our 3 clinics, so that if there are patients who are falling outside of our reminder system who need to be called back in for a recheck, that we can get them back in to the clinic. So overall, in the 4 years with these things being implemented, we did see remarkable improvement. And so for patients with diabetes, our blood pressure control went from 73% to 97% for the 3 of us practicing here at Ellsworth. For those with ischemic vascular disease, it was up again to 97%. And then as of the audits for last year, for 2012, our blood pressure numbers across the Ellsworth Medical Clinic for all patients was just above 90%. We're a few weeks shy of getting our final audit data for 2013, so hopefully we've been able to maintain it, but it has been something that we've seen fairly consistently. And as they mentioned, we had the honor of being named as one of the 2 clinics in the United States that were Hypertension Control Champions for 2012. And we have instituted a lot of the same changes that we made here at our small clinic have been rolled over into our other 2 clinics. And I understand that we're being considered as the River Falls Clinic is being considered as a finalist for one of the Million Hearts Awards for 2013, and we're anxiously awaiting final results to see if maybe our sister clinic will win that again. So for us, we needed a different mindset. We needed to understand that every visit was an important one for addressing chronic disease, including hypertension. And then one of the things that we found is that high-tech tools don't replace low-tech tools, and it's hard to do any of it without doing it all together. So we need to involve everybody, include everybody in order to make a difference.
Great. Thank you so much, Dr. Lajuski. It's a great presentation, and the outcomes that you've seen are really pretty mind-blowing as far as I'm concerned. So some really great information. Does anybody have questions?
Well, I'll keep up the pattern. This is Lloyd again. Again, fantastic presentation and outcomes. I have a different question, and this outcome exemplify? There are 2 hypotheses floating around about the Million Hearts campaign and what makes it tick. Probably more than 2, but one of them is that what you're really doing is putting together systems. You're shifting from the individual mindset to systems of care or team models, and you described that beautifully. So that's model A. The model B is that what's happening is it's a shift of attention away from other illnesses towards hypertension. And in this case, that we may actually see ratings fall for things like depression or diabetes. Since the evidence on this is mostly absent. I'm curious what I have a strong guess what the answer is, but I'm not you. What's your experience?
I think overall our experience has been that the things we've learned from hypertension have improved our care in other areas. I don't feel like it's distracted us from other chronic diseases for the most part. What it's helped us understand is kind of the process that you need. We think it's really important that your pre-visit planning, that the staff is looking at patient charts before the patient arrives so that we're addressing any issues for any of their chronic diseases at the time of. If they're coming in for a sinus infection but they're due for an A1C for their diabetes, well, let's catch it while they're here. We found that care coordinators are really important. They can get to know patients. So I think that having people who are responsible for monitoring patients between visits is something that's important, and that's true whether it's hypertension or depression, that's really important. And so I think overall you take the lessons, when you get good at managing one thing, you take those lessons and you apply it to everything else, and I think that's tended to work really well for us.
By the way, I really think that's true, though there's argument about it. And maybe actually within the Million Hearts program and within these examples, a point worth extracting or dealing with, because it is one of the criticisms of the program, I think has a wonderful answer, which you just gave. The extent to which we can show that it's about building an infrastructure around one of the most common concerning problems, but it extends to others is a critical issue, and beautifully said.
Well, and I think the other thing that we learned early on that I'm a huge advocate for is that that measuring and distributing the data is really important. And I know when we first started our processes where we would do these chart audits and then we individualized it by providers and we would distribute it and then we would also post it back in the staff area of our clinic. And inevitably, there were physicians who were absolutely convinced that they were being assigned patients that weren't theirs or that their patient base was just so much harder. But what we found is that if you keep measuring it and posting it, protest all you want, the numbers get better. So I think that's the other thing. If what you want to do is improve asthma care, then figure out what your measurements are, audit for it, and distribute it, because protest all you want, numbers are the numbers. So that's my personal bias.
We share it.
Any other questions? All right. Well, in the interest of time, we will go ahead and move on to the next agenda item. Dr. Lebowski, thank you so much for joining us. You're welcome to stay on the rest of the call if you'd like, but if you need to go, that's just fine.
Yep, when they signal me I've got a patient, I'll scoot off, but I'll listen in until then. Thank you for the invitation. I appreciate it.
Thank you so much. All right.